Today's webinar is Beyond Outcomes, Tools for Better Treatment Experiences. And just want to say we really appreciate you joining us this morning. Before we go on too much further, I'd just like to start with some acknowledgements. I would like to acknowledge the country on which I am on today and the lands on which all of you are joining us from. I'd like to acknowledge that I'm coming to you from the unceded lands of the Gadigal and the Birra people, the traditional custodians of the country that NADA office stands on. I'd like to recognise and express my gratitude for First Nations people's continuing connection to land, sky and waters, and thank them for protecting this land and its ecosystems since time immemorial, and for their tireless work and generosity in sharing this connection with us. I pay my respects to elders, past, present and emerging, and extend that respect to any First Nations colleagues also joining us today. I acknowledge that sovereignty has never been ceded, always was, always will be Aboriginal land. And NADA also recognises with respect and pride people with living and lived experience and our peer workforce who share their experiences of substance use, of living with mental health distress, and their stories of healing and recovery. We acknowledge their courage and their vital role in shaping policy, sector development and enhancing service delivery. It's through their guidance, the sharing of their diverse experience and their peer support that lives are saved, service experiences are improved and health outcomes are realised. We acknowledge that this courage and persistence ensures that their voices are heard, and it creates awareness in their calls to action against stigma and discrimination in our community. Firstly, need to say we appreciate and we thank you very much. We understand that times are busy, and we acknowledge that sometimes finding the time to attend these webinars and training takes a bit of rescheduling in your diaries. But as always, at NADA, we appreciate your support. So on that note, I'd also like to just mention that we have the AOD Awards, which will be awarded at our upcoming conference in June. So if you have any amazing colleague that you work with that you'd like to nominate for this year's awards, we'd encourage you to do so. Nominations close on the 4th of April, and you'll notice there's a little QR code down in the right-hand corner, and you're welcome to scan that, or you can go to our website for more details on that. So what are we going to cover today? We're going to just do a brief overview of the clinical care standards. We'll do a little bit of a refresher on some of the most commonly used measures. So we'll look at ATOP, the K10, the severity of dependence scale, affectionately known as the SDS, the quality of life, and then we'll actually have a bit of a look at some therapeutic considerations for use. And I guess the other thing is we'll look at the therapeutic application of the way that we use outcome measures, and really, I guess, holding on to the concept that there's much more to it than just the results and the numbers. It's really important, I guess, to acknowledge that all of our service settings have a commitment to ensuring that we have safe treatment environments. And I'd just like to bring your attention to the Alcohol and Other Drugs Care Charter, which has been significant amount of work has been put into this. And it's just a reminder that our service settings always are committed to, really transparent and upfront communication, that our environments are engaging, and that we very much think about right care in the right place at the right time, treatment matching, which we'll touch on a bit later, safety, privacy, confidentiality, and of course access to care in these supportive environments. So obviously lots of people have heard about clinical care standards. We had some very dynamic workshops that were run facilitated by Susie Hudson from the Ministry of Health and supported by NADA. But just a refresher, these have been developed by the values-based healthcare team. And there was a lot of consultation. We had representatives from NGO and government alcohol and drug services, as well as a number of lived and living experience consultants who provided their input. The clinical care standards sets out basically the standard of care and the activities that people can expect at each stage of treatment. So for us, we're committed to quality care and it doesn't matter the setting. And I just need to mention that, you may use different names for these levels of intervention. But we usually see intake or sometimes a pre-intake and then an intake. We provide comprehensive assessment, care planning, risk identification, response and monitoring, obviously ongoing monitoring and review and transfer of care. The way that these are delivered will always reflect and be responsive to the treatment setting. So they might look different in different settings. For us, we're setting the standard for high quality treatment. So for clients and families, what that means is we're going to have clear expectations for clients and their supporters. We ensure that our work reflects a person-centred care approach, which is underpinned by a very strong commitment to social justice and human rights. For service providers, what these standards do is they identify the components of what quality care for each treatment stage involves. And also for us as a workforce, it identifies the required skills that we actually need to be solid in the way that we deliver each of these interventions. We have lots of opportunities for collaboration. So we have, a building of greater networks between our agencies and interagencies. It strengthens collegial cross-sector relationships. It allows for a shared understanding of treatment and service delivery systems and language between non-government and government AOD sectors. It also means that we provide improved treatment matching and continuity of care. Just briefly, that just shows how it's all tied together. I won't go through this slide. You will be given the slide. So this gives you a little bit of an indication of the way it all fits together and particularly around clinical governance. I guess before I go too much further, I was a bit remiss in introducing myself. My name's Antonia Ravisi. I'm the Clinical Program Manager here at NADA. I'm also joined by some supporters today, which is Michelle Campbell, who's our Clinical Director here at NADA. Also, we have May Lin Lee, many of you know, looks after our database and also the research here at NADA. And we're also joined today by Alison Beck from Wollongong University, who will have a bit of a chat towards the end about an opportunity for you all to be involved in some interesting and very relevant research. And so Alison will run us through that shortly. What we're going to be doing in an effort or in an attempt to try to be interactive, it's a bit challenging sometimes with these particular webinar platforms, is we will give you an opportunity to share a couple of thoughts, and Michelle is going to be monitoring that input. So the chat function is turned off, but if you could use the Q&A function, that would be fantastic. And if you'd like to send your comments or thoughts or questions in anonymously, just tick the little box. It's just down to the bottom of your screen, and that way you can pop your thoughts in without being identified. So I guess to start us off, without obviously writing a big essay, maybe if you could pop into the Q&A, just a couple of words around maybe what are some of the challenges or sticking points you might experience when you use outcome measures. And then the second part of this is on a scale of kind of 1 to 5, and this is not about our skills, it's more about our sort of confidence level. How do you feel about your therapeutic use of outcome measures? So I'll just give people a moment to just pop in a couple of words, just make sure that we can respond to those as we move through. I'll also just mention at this point that we would like to recognise that many of you and well, all of you will be highly proficient in your use of outcome measures. And so the intention of this webinar is really just to provide a bit of a fresh look at the way that we use outcome measures as a therapeutic tool. So Michelle, have we got any thoughts, comments, ideas in the Q&A at this point?
We've got one so far, and it's Christy saying time.
Time, absolutely. Would definitely echo that, and it's probably a feedback that we hear very commonly.
We've
Um,
got more coming in now.
Beautiful. Go for it, Michelle.
So we've got a few in the chat. If you can stick them in the Q&A, that would be really good. So someone feels comfortable administering, but less comfortable that there's not a good way to make the feedback feel engaging, which is a
Beautiful.
really good point.
Mm-hmm.
Meaningful engagement from participants, especially at intake comprehensive assessment level. Someone's given it a 5. They're very confident due to the work history, which is good.
Great.
And we've got another couple in the chat. So we've got provision of explaining why these tools are utilised and information is collected.
Fantastic. All right. So let's move through, and it's fantastic if you're feeling confident, and would definitely echo that there's a bit of a balance between working on the engagement, ensuring that people feel comfortable, and also ensuring that we get through these outcome measures and do it in a way that still holds the importance of the therapeutic relationship. Thank you, everybody, for your feedback. It's really helpful.
I just mention one more. It comes
Please.
back to the SDS, which I know a lot of people can struggle with. It's working with clients who are not actively using substances and continue with abstinence. So we'll get to the explanation a bit later on about how to utilise the SDS productively.
Yeah, and I'm really glad that thank you to the person who popped that in because it's a very commonly raised question, and we have actually made a point of making sure that we covered this in the webinar today. I'm not going to go through, like, this is not about, the clinical care standards, but just to give you context, we've kind of added them in so that you can see where the outcome measures fit. So if we just look through this, what we're going to do is just draw out what is the information that ideally we're looking for when we do an outcome measure at these particular stages in treatment. So if we start off with intake or pre-intake, or you might have a different word for it. Really, I guess this is our intention here is usually around some psychoeducation, or it could be potentially some harm reduction information obviously about the service. We may be looking at referrals or pulling in the support of other agencies. And most importantly, our intakes are about initial treatment matching, just to make sure that our service is the right fit. When we're doing when we're doing the outcome measures, the information that we're really importantly looking at is we want a baseline. So we need to get a picture of where people are at when they first enter treatment. The other thing is to think about, and we will use this term, is the status of the relationship with substance. So the way that we often describe the way that people use substances, it's a relationship. And so this gives us a sense of where people are sitting with that, how they're feeling about it. It also helps us understand the level of dependence, and that's not just physical dependence, that's also psychological, mental, and emotional dependence. It also highlights for us any psychosocial needs, and we get a really good sense, or an initial sense, I should say, of a person's general well-being. And this often will lead into things like a risk assessment, and also safety planning. I guess I'll throw in here that if you have any questions as we go through, please feel free, pop them in the Q&A, and Michelle's going to monitor that and we can answer them as we go rather than necessarily saving it up to the end. For a comprehensive assessment, and again, you will do this differently depending on your service setting. Really, ideally, what we're looking for is we want a really solid, holistic assessment, which we use then that information to inform, our treatment plans. And it's often through that we can prioritise what the client's treatment goal is. I'll also just mention that in terms of language, I will use the term client. I recognise that there are other terms, but just in order to keep consistency in the way that we deliver this information, I will use that term. The information that we are looking for in a comprehensive assessment from our outcome measures is we would like to identify any protective, any risk, and any deterrent or interruption factors. And what we mean by deterrent and interruption factors is things that might get in the way, things that might interrupt the treatment or may mean that engagement in the treatment is kind of short-circuited. It also helps us understand people's networks of support and also social, community and cultural connectedness. For care planning, again, you're all very familiar with care planning, and it's very much often about focusing on goals and responding to prioritised needs. And so for us, we're looking at the information we want from outcome measures, particularly here, is that throughout a person's, particularly once they're engaged in treatment, we have these check-in points. And it's about monitoring not just progress, but people's experience of being actually in treatment. It also means that if we're doing these regularly, what we can do is identify any additional risks or if there are any emerging concerns that again might impact on a person's capacity to engage in treatment or stay connected. And the most important thing, and this is often one that gets kind of dropped off the radar, is that outcome measures can be an incredible validation and an affirmation of people's efforts. And often people can be struggling along and feeling like they're not getting anywhere. But once you actually see it in front of you and see the results, it can be a really fantastic opportunity to affirm the effort and the commitment that people are putting into the treatment. Risk identification, response and monitoring. Again, we would do this throughout treatment and we do it at every stage and we would do it as needed. Again, the information that we're looking for is, we're screening. We want to identify and we want to monitor levels of risk. This helps us shape any safety plans and it will also trigger us if we need to respond immediately or fairly quickly. The things that we're always looking at is obviously health. We're obviously looking at any levels of risk around substance use itself, but also we're looking at things like mental health. So, suicidal thoughts, self-harm, disordered eating. And also we have a number of safety issues depending on obviously the people that you're working with, domestic and family violence, people's engagement in sex works, for example, some of the lifestyle stuff, homelessness, and obviously child protection. Got a couple more of these and then we'll move into the therapeutic application. So basically we use, as well as obviously part of our monitoring and review of treatment, is, these are usually scheduled, but they can also be unscheduled. So it might be as needed if you're feeling a bit of a rupture in the relationship, therapeutic relationship, or you're feeling, or the client's saying to you, look, I don't know if I'm, is this really happening? Is this, I'm not sure if this treatment's for me. So they can be unscheduled appointment. And in this, at this time, this is where we do collaborative reviews. We take time to do a reflection on people's progress, perhaps their priorities. We might ask the question, are we still the right service match? And it's also a fantastic opportunity for us as workers working with our client to actually have a review and a conversation about, how's our therapeutic relationship going? And what's your experience of the service like? Is this, are we going okay? Is there things that we can do to support you? Are there things that we can do to actually make sure that your engagement feels productive? Our biggest question is at these reviews, is the treatment still effective and is it responsive, and is it a good fit still to a person's needs? And most importantly, transfer of care. So really, this is where we, collaboratively. So, again, these don't have to be extensive. They can be fairly short, brief, and simple. It's a summary of treatment. Usually, we would ideally start these at the start of treatment, and then at certain points throughout treatment, we'd revisit our transfer of care plan, and we would finalise it just prior to the client leaving the service. The things that are really important for transfer of care is that we make sure that we've had a relook at any risks and we've identified protective factors. This helps us guide around safety and harm reduction planning. It also is a time for reflection, allows clients to actually see the results of their engagement in the service. And we do that through the review of outcome measures as well. It also helps us identify if there's any additional treatment and psychosocial supports that a person may need. All that information is incredibly useful for a client who is potentially going to another service or for clients who where the transfer of care is to themselves. Let's move into the therapeutic application. So again, need to acknowledge that, I'm sure all of you do this in the way that you deliver the outcome measures. Again, just a bit of a refresher, thinking about or an opportunity to reflect on how we're going with this is a chance to have a look at the collaborative relationship. So that's the relationship that I have with the client or the person that I'm working with. Most importantly is that we look at the process. So what's happening in treatment. We look at the results of the outcome measures, but without the narrative, it's often quite meaningless for people. And I think someone mentioned that in terms of engagement, and we'll just throw around some couple of tips for maybe how this can be managed. The really important thing that outcome measures do is it invites conversation, and it's almost through the structured questions that it allows us to kind of springboard into a deeper exploration of how a person is going. It actually allocates some space for review. So, if we set this up in the beginning and we, let the client know that, look, throughout the time that we work together, we're going to make these times and they're really a bit of space for you to stop, for us together to look at how things are going. And it's really important that we allow that space and that time for a bit of reflection. And often that's incredibly important for a person who's working really hard to stay engaged and working through a range of issues and concerns. Having a little bit of time to stop and reflect is incredibly important. And of course, we do these at regular intervals. And ideally, we can plan those out to some extent so that people are pre-warned, prepared that, we do these at first contact or maybe intake. We're going to do it again in a month. And then how about we do it again in 3 months and we might just see how things are going. And we'll do this at the end of when your contact with the service is coming up. The really important thing too is as a service system, so as an AOD sector, it means that we're developing a service environment and a culture of feedback. So what it does is it says to all the people that we work with, look, we're open to stopping, reflecting, and really hearing about whether or not this is effective form of treatment for you. And that's incredibly powerful for people. It's also a mechanism of quality improvement. It's also accountability for services and also the broader sector. We know the work that we do works, but in order for it to be substantiated and also have a mechanism of, ongoing accountability to the people that we work with, it kind of provides a structure to that, and that is incredibly important. And Michelle, if there's any questions, I'll just ask you to kind of call out and
Yeah,
we'll make some space to respond.
there was just a comment from a bit earlier around the quality of life and the point that when someone feels really low, how you how can you rate your quality of life because it can feel a bit dehumanizing.
Yeah, that's actually that's a really powerful point. And we might actually touch on that shortly when we move through these measures. Thank you. Thank you to the person who popped that in. These are some therapeutic considerations. So, I guess from our perspective, talking about outcome measures, it would be unethical if we didn't actually acknowledge the importance of data sovereignty for Aboriginal communities. That is a whole area in itself, which, I don't have the expertise to speak to. However, it's important, very important, that we sort of have that front of mind in the way that we record our data. And we do have some resources that you are welcome to follow up after this. We're aware of the impact of trauma, and I know that's often raised as a concern in some of the questionings that we have in some of the outcome measures. We have things to think about around literacy levels, learning and developmental disabilities, some other disabilities such as vision or hearing, people who are neurodivergent as well. Again, these are things for us to be sensitive to and to be thinking about the way that we actually present and deliver the outcome measures. We have intoxication and withdrawal, cognitive capacity and memory recall. And I think, it's really important that, I don't necessarily always remember what I did last week in every single detail. And so we may need to develop techniques to support people to be able to, recall what happened 4 weeks ago, as many of the outcome measures ask people to do. English as a second language means that, some of our questionings have a particular nuance to them that may actually be really unclear if English is not your first language. And we do need to recognise, as someone said, with the quality of life scale, people's circumstances are dynamic and changeable, and so a person may present one day, fantastic, things are feeling pretty solid. Movement is, they're feeling the results of their engagement in treatment. To other situations where a person may present and things are pretty tough. We also need to recognise cultural, financial, and settlement loads for refugees and new arrivals. We could literally do a webinar on every single one of those therapeutic considerations. Just going to throw open to you now. Again, just briefly share your thoughts in the Q&A. Like, what do these considerations highlight to us about our approach to using outcome measures? And again, you're welcome to tick that box if you'd like to enter your comments anonymously. So just thinking about that list, you don't need to, speak to every single one of them, but maybe there's one that sort of stands out for you in terms of the people you're working with. What are the things we need to think about? When we're using outcome measures, recognising that people's situation and people are diverse. Don't be shy to share your thoughts. And Michelle, I'll just ask you to have a little look at the Q&A and maybe check in on the chat.
Yeah, we had a question around sending through some links on the data sovereignty information, so we can do that, and we can stick that in the chat.
Yes,
Um,
absolutely.
and there,
And we'll make the PowerPoint available to you all because throughout we've added some QR codes as well.
and so far there's just one other comment around the program that someone uses to input data. That there's no easy way to compare the previous outcomes to the most recent, which makes it a bit tricky to be able to reflect on that with the client.
Yeah, it does. And we do need to recognise that some of our recording systems are limited in being able to provide people, particularly with a visual picture. Um, I recognise that this next suggestion does require a bit of work. There are workers that I've spoken to and worked with, teams I've worked in, where we've ended up using an Excel spreadsheet, set one up for our clients, and which allows us to be able to show a little graph or a picture of what is happening, but do need to recognise there are limitations in being able to sometimes show those visuals, which I would agree is incredibly helpful for people.
We've just got a few more coming in now, which is around the connection you've got with the client. So it's the info you need to know, but it's about asking the questions in a conversational way rather than just ticking the box.
Beautiful.
And ensuring you're asking and responding in a human way. So making eye contact where it's appropriate and acknowledging people's responses as well.
Yeah, absolutely. Absolutely. Very, very important. Thank you. Let's take a closer look. So, again, you could literally do a webinar on each of these. So we're going to move through and we're just going to bring out some of the key points for the ones that we commonly use. Um, We'll talk about the ATOP briefly, so the Australian Treatment Outcomes Profile. And, we know that this was adapted from the British Treatment Outcomes Profile. It's designed so that you can use it face to face, you can use it on the phone, and some services do have the capacity for clients to self-complete online, or they use a iPad or something like that. And we are seeing the use of the ATOP in, New South Wales, South Australia, so pretty much most states now. I do need to mention that the Ministry of Health is rolling out online training workshops. So I have to say I have attended one of these, and even as somebody who has used ATOP a lot, I definitely was given a very nice fresh look at how to use the ATOP. So we would highly recommend that if you have an opportunity to attend one of those, that you do so. And you're welcome to reach out if you need more information around that. Just want to cover this because these are commonly, I guess, raised points around some of the question structure. So section 1 obviously covers substance use, frequency and quantity, and section 2 is health and well-being. We have those yes, no, and self-rating questions. And also there's a part of it which you rate your psychological, physical health and quality of life scale. So I'm going to talk about these ones, particularly the pattern of use, because this can sometimes be hard for people to remember what's been happening in the past 28 days. Ideally, they're broken down into by week. And it's important to just look at it week at a time. And again, the most important thing that we need to reassure people is there's no right or wrong. So just we work through, did the use follow the same pattern, as last week or the week before? Or did you have a week when sort of felt like, things were quieter than usual or more chaotic than usual? And quite often the little tips is if people are struggling to kind of recall is, did anything particularly happen in that past week or over the past, 28 days that might help people fill in the gaps. And we do that for each of the substances that are listed, and we try to record the number of days used. And again, this is not necessarily about it having to be accurate. It's about a mechanism that kind of allows people to reflect and allows people to start to think about, okay, so what was going on for me last week? So I think it's really, it is really important to stress to people, look, it's okay. Don't, if last week was a bit of a blur or 4 weeks ago was, can't quite grab it, let's just try and work with what we can remember. Really important one, and this was brought to our attention recently, and I guess wanted to share this with you because it was a good reminder. There is a section in the ATOP that talks about other substances, and sometimes, by the time we get to other substances, you can see your client fatiguing a little. We may sort of jump on. Or kind of brush on and kind of move on to the section 2 questions. As a worker, it's useful to just stay across some of the current substance use trends. For example, we've got GHB and nitrous oxide up there at the moment. So we are seeing in certain demographics, in certain communities, an increase, for example, in GHB use, particularly being used alongside methamphetamines. And we also, in other communities, we're seeing a bit of a rise in the use of nitrous oxide. So if you are picking up a bit of a current trend in the groups of people you're working with, ask them. It's a fantastic way to take the opportunity, say, to provide some harm reduction or some overdose prevention information. And quite often, if we don't ask, people don't think to tell us. Really importantly, you don't need to be an expert. So clients hold this knowledge and a way of engaging people. And I realise we don't want to get into a big drug rave. So we obviously balance that out with sensitivity. But clients will tell you, oh, this is what's happening, this is what's going on. And this can be such a useful guide for us when we actually ask this question. Recording substance use quantities, and this is a really good one to revisit and a good reminder. So with the alcohol, it's recorded in standard drinks. And I'm not sure about you, but to be honest, sometimes I wouldn't know what a standard drink looked like. It's helpful to sometimes have a visual guide. There's plenty of them, that we can get online, to just sort of show people and say, what do you reckon? Do you think it's this? Michelle, and I were talking about this, and Michelle gave me a great example that somebody that she'd been working with was saying, I have 2 glasses of wine a night. With a bit more exploration, it actually was revealed that they were those extra large glasses, which literally held half a bottle. So really, that meant that the client was drinking a bottle of wine a night. So sometimes having a visual guide can really help to prompt people and get people to think about, oh yeah, I think it's that amount, or this is what I'm doing. Other categories, we're looking at non-prescribed use and the use measures, but we need to use the descriptors from the client. So examples would be 30 cones a day, a quarter of an ounce, a point, $50 a day. So if a person can't tell you the amount, but they know how much they spend a day, then that's what you record. It might be a pill, a cap. We don't need to try and have a little calculator and work it all out. This is really about using the client's words and their descriptors. I was just actually going to mention before we move on there that there is, again, this is in the PowerPoint. You can get a copy of this. There is now a guide put out by Insight, our friends at Insight in Queensland, which is actually a guide around sort of the rough amounts, costs, and how substances are sold in quantities. And there is a QR code for that on the previous slide that you're welcome to go to and download. It's just a one-page chart, really easy to refer to. Just going to move to the Kessler 10. Need to acknowledge that obviously, some services are using the Kessler 5, but really the kind of key applications are the same. So self-reported measure for psychological status, and we look at the past 4 weeks. It's used to identify levels of psychological distress, and it helps us identify whether or not there's a need for some further assessment or inquiry around people's levels of anxiety and depression. And we also have questions there to assess the level of nervousness, agitation, psychological fatigue, and depression. Just wanted to mention, and this is incredibly important when we're thinking about accessibility for our multicultural communities and multi-faith communities, is that the Transcultural Mental Health Centre have a Kessler 10 version, which is available in numerous languages. So I think they've got over 20 language versions in various languages, from Japanese, Italian, Greek, Mandarin. And so I would strongly encourage people who are working with different populations to explore that option, and particularly for people where English is not their first language, because the way that particularly emotional states are translated can be heavily nuanced in different cultures. So yeah, there's the QR code there if you're interested, but again, you'll get a copy of this. We also are looking, obviously, at picking up if there's improvements or people's psychological health is declining. It's also can be a mechanism to pick up whether or not there is an increase, for example, in symptoms for somebody who has a diagnosed mental health condition, for example, bipolar. You've all seen these before, so I, won't go into them in great detail, but what we do know is that the higher the score indicates the greater the distress. The questions 11 to 14, some services may not be doing these, and that's okay, but it's worth just to mention here. The intent of these is really to try to open or widen the picture a bit. We don't include these in the total score. This helps us understand the impact, and it helps us understand if there is the level of, I guess, disability, and it will help us identify whether or not people need some additional psychosocial supports as well. As you can see there, we can kind of see our ratio, which gives us an indication of levels of distress. Let's talk about severity of dependence, and hopefully to the person who asked the question about using this with people who haven't used substances, hopefully this might shed some light on that. So obviously it's a 5-question reflective tool. It actually measures psychological dependence. So it's quite different to, for example, a withdrawal scale or some of the other clinical mechanisms that are actually designed to assess level of physical dependence. So its primary focus is psychological dependence. And what we're talking about there is we're looking at trying to understand some of the emotional and mental health drivers that sit behind substance use. Some of the things that people might talk about in this, so if you're going to set this up with somebody who hadn't used substances for a while, you might have a conversation around These might be some of the things they might be experiencing, and this is why we're going to do this severity of dependence. Is we really want to understand. We understand maybe that you're not physically dependent anymore. We just want to get a sense of how you're traveling, how you're going with things like cravings. How often are you having really preoccupied thinking, maybe about substance use? Are you experiencing, for example, loss of joy associated with passions and interests? Often these can lead to really useful conversations about just the experience and belief that substances are needed to socialize, go to work, manage emotions, and for example, in intimate relationships, something that often doesn't get touched on is for quite a number of people with trauma, and something they often don't bring up is, substances may have been a key part of them being able to have physical intimacy, or hold relationships. And so this can lead to a really powerful conversation about, how are they feeling about their capacity to have intimacy or to have relationships with other people without the use of substances. It can really help unearth some of the grief and loss, and again lead to some really important conversations. And for us as workers, we can acknowledge the grief and loss that people can experience when they stop using substances. It can help people understand that there's no shame attached to that this is actually a normal and natural and completely understandable process that occurs for people when they make significant changes about the way they use substances. So the way they have a relationship with substance. It also can often lead to conversations about compulsion to use while people are holding an awareness of the impacts. And that can be a very difficult um, experience for people to actually articulate, to be able to say, I know that it's had all these, really detrimental impacts in my life, and yet I have these, driving desires and thoughts of wanting to use substances. So that's really the intent and the focus of severity of dependence. Obviously, that's it there. And I just, the question that's quite useful in terms of safety planning, prevention planning, whatever term you choose to use. Question 5 is incredibly helpful in guiding some of those conversations. How difficult would you find it to stop or go without? And it can be attached to, okay, so when you're in those situations where you're looking at having intimacy with a person, how difficult is it going to be for you, particularly if there are substances on the table or being offered, for you not to choose to go and use, and yet you're driven by a strong desire for intimacy. So we can have some incredibly powerful conversations.
Just got a comment, Antonia, thanking you. That was an excellent explanation of the SDS.
My pleasure. Glad we can shed some light. So it's a really it's important because I think it can lead to some really powerful conversations. Quality of life, and I do want to acknowledge the person who popped in the Q&A that this is a tough one, particularly when you have a person that is, presenting in, a really down state. It can almost feel uh, insensitive that we're going to run through these questions. So we'll talk a little bit more about that in a moment. The quality of life is really about identifying 8 domains. The way that we think about this is about how these things are going to sustain a person and also impact on their capacity to engage in the treatment as it stands. And it also gives us a really solid picture of their overall well-being. Really importantly, these are not necessarily scored, and we don't, have a total score and then we kind of, next time we look at it, we look at the total score. This is actually where we look at each domain and we would compare it. And this helps us again with holistic care planning and the treatment and matching. Um, the other important thing is that when it's potentially tied in with a reflection on, for example, the K10 scores, quite often people will get a sense, look, I'm doing all of these things. I'm doing everything that I've been asked to do to engage into treatment. I'm following the advice I've been given, and yet I'm struggling with these things. It's really important, again, that these conversations allow people to separate their use of substance from what is happening with other situations. So, for example, a person's may have health issues, for example, pain, and it may have been a key driver of their use of substances. When they reduce substance use or they're trying to stop, they may find that they're now left with pain. It would highlight for us that rather than go, oh, yep, you've got pain, it is like literally a big, massive kind of flashing light to say, this person's going to need support around managing pain. If we don't, and if we don't include that in our plan, then really we're setting a person up to potentially struggle to stay engaged in treatment or to stay engaged in their goal around the way that they're choosing not to use substances or, their reduction of the use of substances. So we really use these as an opportunity and we can say to the person, look, this is about helping us understand whether or not you need additional support because it's not just about changing the behavior of substance use, it's about where substance use fits in the whole context of your whole life. And it allows us then to be able to reassure people that we can actually organise additional support, or perhaps, if you're engaged in counselling, then how about we look at one of these particular issues and really break it down and really focus on that because this is going to impact on your capacity, not your willingness, your capacity to engage in treatment. Just going to check our time because I'll get excited and I don't want to hold you all up. Okay, going to talk about or move to very much that therapeutic perspective of the way we use outcome measures. Again, you could spend a lot of time on probably each of these. So these are just some key refresher points for us to sort of reflect on. The most crucial and point, I guess, in setting up the way that we use outcome measures is to develop and maintain safety. It's crucial. We need to be mindful of being transparent, and this is explaining very clearly the purpose. We do this because it helps you and I get a really clear picture about how things are going but also how our treatment is responding to your needs. We need to clearly talk about where it's recorded, and we also need to talk about if there's any implications. So, what I mean by that is, for example, a person with corrective services, part of their conditions may be no use of cannabis or no use of methamphetamines. If they do one of an outcome measure, it may lead to a conversation where they disclose substance use. We need to be very clear with people that if that information comes up in the conversation, what are our responsibilities around that information and what might be the implications? And again, transparency is key. Again, I kind of covered that around the purpose and the intent. But the second part of that is we need to talk about how these measures and how our conversation around these measures is going to kind of inform the treatment planning and monitoring. So monitoring can be a very terrifying word for people. The idea that someone is checking whether they're doing treatment right or not. So we need a conversation which reassures people that it's also about making sure that our service is still meeting your needs. We don't want to see you in a service where we've identified some other needs and you're just slogging away and there's a big large piece of the support puzzle missing. Very importantly, and this was something that I heard in some recent training, which really stood out for me, which I think is important to share. Give back what has been lost. So agency is very important. And so giving that information, explaining to people what happens to the results of outcome measures, um, also planning to do these review sessions or to have these times where we stop and do these outcome measures can create a mechanism predictability. It's those things that will add to the safety. We also need to be incredibly aware of cultural safety for Aboriginal people and people from multicultural and multi-faith backgrounds. And I'll touch on that again in a minute. And really to stress that there's no right or wrong answers. So how a person presents on the day is how they present on the day. The results reflect how they are feeling today. It's not a reflection of their lack of willingness or their lack of commitment. This is a reflection of how they are today, and there is no right or wrong. Often, I need to mention that, particularly when we have great relationships with our clients, there can be an incredible loyalty to us as workers. They may have a sense of sort of responsibility of doing the right thing, and we may actually need to have that conversation. This is not going to mean that I think you're not trying hard enough, or this is not about your willingness for change. Need to mention cultural safety. It's incredibly important. And this quote, again, was shared with me recently, which I thought I would share because it's nice and simple. Cultural safety is an environment that is spiritually, socially, and emotionally safe, as well as physically safe for people. So, where there is no assault, challenge, or denial of their identity, of who they are and what they need. It is about shared respect and shared meaning and the experience of learning together. And I feel that that is appropriate for all the people we work with. The experience of learning together, I guess, for me, is the statement that is the standout when particularly we're talking about the way that we use outcome measures. So we're going to learn about what's happening for you. We're going to do this together. We're going to share this and we're going to make sure that, again, I am responding to what you need. Other tips for safety, creating safety, permission seeking. We can sometimes get a bit rote sometimes in that we just do this stuff all the time, and it's good to just have that quick reminder, that bit of a refresher. Seeking permission, it creates agency. Are you okay if I close the door? Would you prefer to sit outside? Are you okay if I actually do these outcome measures? I know this is our scheduled appointment for this. Are you all right if I actually do that today? Can we move on to the next one? So again, really important. We always provide agency. Opportunities for collective engagement. For some people, the idea that you are going to be having to answer these structured questions can be highly anxiety provoking, and there may be an opportunity to bring in a friend or a chosen family member. And this is a fantastic opportunity to bring in the expertise of peer workers because they can often reassure the person, but also speak around the way outcome measures are used and actually reassure the person, from the perspective of somebody who has been through it and who knows what the experience is like. Okay, a couple of other really important points. Recognition and validation. So we always, and I know that this was in the comments, and again, a fantastic reminder that we always approach these with compassion and curiosity. We ensure that we have strength-based discussions. And really, the other intention is when we review these measures, they are an opportunity to validate the person's efforts. So we do use the word progress a lot, but really it's about the person's efforts. We acknowledge that despite all odds, they've been turning up at their appointments. Despite having some pretty distressing days, they've stuck it out in rehab. Despite receiving that really terrible phone call, just after a group, they're still here. So it's another opportunity to say, we see you, we see the work that you're doing, and we recognise it. We also have the chance to really actively listen and acknowledge their experience of being in treatment. What's it like for you? How's it going? How are you finding being in that noisy communal dining room with all the people? And, how are you finding sharing a room with that particular person? We can also explore, how are they finding that particular specific treatment approach? Is that working for you? Or I noticed that you struggled. It's interesting, you're saying you're really down today. You're saying you don't feel connected to people. It's come up in your quality of life scale. You're in a community, you're in a therapeutic community. So talk to me. What's going on? Are there people that you're not feeling that you can talk to? Are you feeling isolated in a community? So these are incredibly valuable and important conversations. Trauma informed and trauma responsive. So they can really help us understand and lead to, again, these conversations that increase our awareness of people's experience. But it's very important as workers that we understand the biopsycho, spiritual, and social impact of trauma. We need to understand that for some people, the idea of sitting down with formalized questions can be highly triggering. We need to acknowledge the impact of contextual factors. Again, because these are structured questions, there's not a lot of room to sort of be flexible and move them around. We need to be aware that for people, perhaps who have had an experience of institutionalization, or pathologization, where their emotions have been labeled in some negative way, where they've experienced stigma and discrimination, or persecution, that just the experience of having to respond to outcome measure questions can be highly triggering. If that's the case, then it's a conversation we need to have that acknowledges that talks about it, and that discusses ways that this can still occur without reactivating people's past trauma. Really importantly, we need to recognise the impact of collective and transgenerational trauma. So again, particularly populations who've been heavily scrutinised, the use of outcome measures can feel like a replication of that experience. Again, incredibly important to have that conversation and to allow the space for people to talk about what that experience is like, and to be able to discuss ways that that can be managed and handled and responded to. We also need to recognise the negative history people may have had from telling the truth. Okay, hope we're going okay. Quote from somebody who I highly respect, Bessel van der Kolk. Traumatized people chronically feel unsafe inside their bodies. The past is alive in the form of gnawing interior discomfort. Their bodies are constantly bombarded by visceral warning signs, and in an attempt to control these processes, they often become expert at ignoring their gut feelings and in numbing awareness of what is played out inside. They learn to hide from themselves. I think this is incredibly important to keep in mind, particularly for people who find it difficult, say, for example, when responding to the K10, to be able to actually say, I feel this. Feeling numb is just as valid a experience as feeling and being able to identify a feeling. And people often may, if you've identified that somebody has, quite complex trauma, or they, have a history of disassociating in sessions or in groups, that we may need to have a conversation. Look, when I do the K10 with you, I notice you're struggling. What's happening? It's okay if actually for you, it's difficult to find the words that actually describe numbness, because numbness is a feeling. Goal setting. Again, outcome measures can help us guide people in setting goals. Um, it helps people be able to have a clear direction, and goals do not need to be complicated. A goal could be, I'm just going to get myself in the door to attend my appointment. In that, we work with recognizing people's capacity and resilience and resourcefulness. And again, this next point could be a webinar in itself, but we're really mindful of performance and supported by mastery goals. So just quickly, performance are about very specifically, this is an outcome I want. I want to stay at detox for 5 days. That's my performance goal. The mastery goal, though, is around a goal that is going to support them to stay at detox for 5 days. So it could be, I get really highly anxious at day 3. My anxiety goes through the roof. I feel like I'm going to literally bust out of my body. So my goal might be, I'm going to practice, I'm going to use colouring in every time I feel like that, or I'm going to make a phone call, or I'm going to practice speaking up and saying I don't feel okay. We have to be very mindful of infantilization. So sometimes, in our intention, and we may also find, some of the questions can feel quite intrusive at times, depending on how people are traveling. We need to be also mindful that we don't dumb things down. And if we choose to simplify the way that we deliver, we always ask about that first. So you looked really confused when I asked you that question. Is it okay if I kind of, maybe try to explain it or reword it? We don't just assume that they didn't get it. Again, giving people a sense of agency. We identify factors that support and hinder goal achievement. And again, really meaningful conversation. So we want these to be meaningful. We want, for example, the SDS to create a picture of the relationship. We want to see if we can be open to creativity. For example, with young people, we might use some photo language, as a lead into doing the SDS in a way, to answer some of those questions that they might find difficult to articulate. And we may need to be aware that people use different words to describe experiences. For example, they might say, I get really jumpy instead of anxious. And collaborative risk management. So this is really important. Again, outcome measures for a lot of people can increase their personal accountability. There's some interesting research that was done, particularly around cannabis treatment, where they were using urinalysis to be able to actually show people a visual picture of the cannabis levels dropping in their system. And what that did was it meant that they felt some autonomy, and it gave them a chance to say, oh, okay, I had that really bad week, last week, but look at my results. It's actually stuff's happening, things are moving. It can inform safety and relapse prevention planning, and it means that we can tailor our harm reduction and minimisation conversations. We also always recognise that clients hold and manage risk all of the time. Okay, we've got all right, checking time. We do have a case study. We have a couple. I'm not sure we'll get to both of them because we're running a bit behind time, but we'll at least have a look at this one. So just need to recognise that when we often do case studies, there can be an uncomfortability or a tension because we can feel like we're generalising in our reflections. I guess I'm just going to say, for the purpose of learning and reflection, that's why we use a case study. If we look at this one, so Amira is 23 years old. She arrived in Australia from Syria with her mother and youngest brother when she was 7. Her family were held in detention for 2 years. She's in a residential program for treatment of dependence to prescription medications. When you do the 2-month measures with Amira, the results of her K10 indicate that she's got an increased level of anxiety and depression, and her SDS score is quite high. So she's having a lot of thoughts and thinking about the substances. So again, you can use your Q&A. What considerations would you be thinking about if you were going to sit down with these outcome measures with Amira? You know, maybe what things might you need to be kind of aware of, and how would you kind of have these conversations? Again, if people feel comfortable and would like to pop just a few thoughts into the Q&A, that would be amazing. And again, Michelle, I'll just ask you to read them out.
Okay, we've got explaining why you're asking them. So revisit the first or the baseline chat about the purpose of outcome measures and how they're going to support treatment.
Yep. Fantastic. Any other things we might be thinking about? You might think about things like, again, potentially your outcome measure. You may choose to access the transcultural version, which would be more language appropriate as well. Amira may have fantastic English. However, again, a recognition of the cultural background, a way of creating autonomy could be we offer that. So, look, I've got a version here in English, I've got a version, here in language. What would you feel most comfortable doing? So, again, we give choice. Um, any other thoughts up there, Michelle?
Yep, we've got a couple more coming in. Psychoeducation about protracted withdrawal symptoms. It's
Beautiful.
and asking if the high K10 scores are typical or that's a new thing.
Fantastic. Yep. And any thoughts around particularly culturally what we might be thinking about, particularly around creating safety?
We've got exploring risk of self-harm or suicide,
Yep.
being mindful that residential settings might trigger trauma of detention, which is a good point,
Fantastic.
and understanding the trauma that she might have experienced as well.
Yeah. Fantastic. So again, we're thinking about our treatment setting and we're thinking about the context of where Amira's, what her history has been. And just again, being trauma informed and trauma sensitive, we would be very mindful. That's not to say residential programs are like detention centres. However, there will be communal living, there will be rules, there may be particular things that are asked of her that could have, incredible resonance with some of her experiences when she was in detention. All right, I'm just looking. We may not have time to do our second one, but it will be in your slides. So I might just move through if that's okay. I'm just going to touch on data sovereignty and then I'm going to hand over to May Lee Lin, who's just going to just remind us of some tips for entering data. Again, I need to say this is not my area of expertise, but it's important for us all working in this area to be increasingly informed. Indigenous data sovereignty refers to the right of Indigenous people to exercise ownership over Indigenous data. Ownership of data can be expressed through creation, collection, access, analysis, interpretation, management, dissemination, and reuse of Indigenous data. And there's a reference there in a QR code to a really helpful resource from the Lauja Institute. And for us, it's our responsibility to become informed, to build our awareness and understanding, and to always remember that collecting data is not culturally neutral. We also ensure that our file notes, so our narratives, are always acknowledged, are contextual and strength-based. And again, that is a whole area that you can do your own knowledge building on. I'm now going to hand over to May from our NADA team, who just take us through just a couple of reminder points for entering data into the database. Are you there, May?
Yes, I'm here. Good morning, everyone. Um, just wanted to apologize that there may be echoes because this is a shared space. So if you could hear someone else at the background, just be mindful that you're not hallucinating. There are people here. So just a quick recap. Out of curiosity, how many of you? So usually when I present, I'm able to see the audience, but this is an online thing. How many of you actually input data into database so that I could gauge um, the extent of data technical term that I would like to use? How many of you, show of hand, who's inputting data into database?
All lots.
Okay. Um, okay, so I assume that about half, half. Okay, all right. So just a quick tip. So in terms of the outcome measures, so there are two tips that the database team I'm on behalf of the database team, which is me, Sam, as well as Michelle Campbell. The top tips would be basically two things. So it'd be the accuracy of the data as well as the consent, which is in another slide. So the data is only as good as what it goes in, because the output, which is the data translation, that bit is only meaningful if the input is accurate. So it's best that the scored measures, the K10, the SDS, and the WHO Quality of Life Index are completed as written, as the outcome measures relies on the standardized tools. So that means that there is no tweaking of the language, as well as it is administered exactly as what is being described on the questionnaire. And it is best that the questions are completed all, because the interpretation relies on the total scores of the SDS, 5 questions, K10, 8 questions, and quality of life, 8 items. We are aware that due to time constraint, that sometimes there will be some questions that are incomplete, but because the questions are incomplete, we cannot actually compute the total score, and that would makes it harder um for us to interpret what does the score means. So what actually happens once it gets translated, once it's entered and collated, there is three things. So first, it will happen at the client level. So Antonio was talking about the client journey. You're able to track at intake what is the K10, and at progress 1 or progress 2, how is the client tracking? The second level would be at the service level. So the managers will see overall at a certain time point, the clients are doing well or the clients are doing not so well. And then the next step would be a sector level. So the outcomes dashboard would be a best visual representation of what happened, because I can talk, yep, nothing. I mean, it'd be easier if I show you. So am I able to share my screen?
You should be able to.
Okay, cool. So, I'm not able to, sorry.
Do you want to just talk to the outcomes dashboard?
Yes. So basically the outcomes dashboard, when you log onto database, when you select the outcomes dashboard, so it is a dashboard, it is a Power BI dashboard that is embedded in the database website. So when you logged in as a database user, you will be able to see, for example, the percentages of episodes that has an improved outcome, a did not change outcome, and a decline outcome. So that is telling at a very high level view how the service is tracking over time. And at the sector level, which is from my view, I'm able to see, for example, if you could see what I'm seeing right now, the outcomes dashboard is telling me for last financial year, I have about 24,000 closed episodes that were completed, about 4,000 episodes that had at least 2 data points, and overall, I can see that the sectors are doing well. Clients who engage with the AOD NGO service, they are reporting a high proportion of improved scores in terms of the quality of life, the SDS scores, the K10, as well as the ATOP scores. So I think that was a quick peek at the outcomes. And then this is about the consent. So at the client level, when we were recently at a road trip and we received feedback that there were service provider that were concerned about consent-related concerns. So it's best that we inform the individual that their data will solely be used for individual treatment planning, tracking the progress of the client, the organizational planning, sector-wide reporting, as well as research purposes, which we will use de-identified aggregate data. I think that's about it from me.
Thank you, May. Did we have any questions in the Q&A, Michelle?
Just around someone who doesn't have their own database, so the data is then exported or imported into Database, so they're unable to see a lot of the trends through their own database.
Yes.
So I was going to suggest they could arrange a time to chat to Sam and May.
Good point. We understand that not all service at an organization level, you may have your own dashboard, and the dashboard is built differently from Database. So you could somehow request to your service administrator for access just to look at Database. Again, we can take this conversation offline, and happy for you to email nada.support@nada.org.au.
Thank you so much, May. I'm just going to acknowledge that we are a little over time, but to let you know that we are nearly at completion. So I'm really hoping that people can stay around for another sort of 5-10 minutes. And I appreciate your flexibility. I'm now going to hand over to our guest. We have Alison Beck, who's a clinical psychologist and postdoctoral research fellow from the University of Wollongong, who's going to share with you an opportunity to be involved in some research around the experience of using outcome measures. So I'm going to hand over to you, Alison.
Fantastic. Thank you very much. And I won't keep people long, but thank you very much for the opportunity to come along and chat to everyone. So I'm part of a team working with Uni of Wollongong, and we've also got collaborators in University of Queensland. We've also been partnering with NADA. And we're particularly interested in understanding a bit more about how to go about this process of outcome measures, that sometimes there might be things that are a bit more important to a clinician, some things that might be a bit important to a client. So we've got a study that's running, it's called a discrete choice experiment. So we're looking at different characteristics of feedback. Is it about when they get completed? Is it about how comprehensive the feedback is? Is it about the type of the feedback that we get back, the timing of the feedback, the frequency? So there's all of these little bits and pieces that might make it more or less likely that people engage in this process of outcome monitoring and feedback. So we've got a survey set up that kind of pairs these in different combinations, asks you to choose, do you like A or B better? Oftentimes it's not a perfect scenario, but by leaning one way or another, it gives us a little bit of a sense of what matters most to people in terms of getting outcome measures completed. So it takes about 15 minutes. It's an anonymous survey. It's completely voluntary. You may already have done it because we have been circulating it through NADA, through newsletters, through the NGO sector. But if it does look a bit unfamiliar, feel free to give it a go. We're really, really super close to being able to finish our sample. So if you're able to contribute to that, if you have colleagues who you might also be able to circulate it to, I've put the direct web link in the chat there, but when the slides are circulated, you can also access the web link in the slides. You can access the QR code. I'll pop my email address as well. You're welcome to contact me directly if you have any questions as well. And we just really appreciate your insight so we can get a little bit of a sense of how best to go about this process in a way that works for clinicians as well as clients.
Thank you so much, Alison. Okay, we're getting towards the end, so just a few little things before we wrap up. Just want to encourage anybody, whether you're from an LHD or from an NGO AOD service, to subscribe to our various comms. We have a monthly e-newsletter with a very much a worker focused. We have a managers newsletter as well, and then we of course have our Amazing Advocate, which is a quarterly magazine that comes out. So feel free, if you haven't already, to subscribe. Want to just give a quick plug for our NADA conference, Strength in Community. It's coming up. And yeah, you will find all of the details on our NADA website under the events page. Again, there's your little subscribey. I realise we're a bit over time, but if there, sorry, Michelle, I meant to give you time to mention the pre-conference workshops. Did you want to quickly mention that?
Just quickly, yeah, we have 2 pre-conference workshops this year. So one is the accidental counsellor for the non-clinical staff, and the other one is around clinical supervision.
Thank you. So if there's any sort of burning comments or questions, feel free to enter them into the Q&A. And of course, you're always welcome to reach out to us directly, and we'll make sure that we can get back to you with a timely response. I'll just allow a moment in case anybody has something burning they need to say. Have we got anything there, Michelle?
Thank you.
Oh, good.
And from Christy, Mammon, thanks so much for letting me join today.
Not a problem. Always happy to have everyone. So I guess this is a question for you to have a think about. Not necessarily going to ask you to share this, but you know, if you have a chance to just sort of reflect on some of the points, I guess, that we've kind of covered today, you know, to ask yourself this question, you know, what is your takeaway reflection from today? You know, maybe something sort of stood out from you, or it gave you an opportunity to look at it from a different perspective. Again, feel free if you would like to pop anything in the Q&A. You're really welcome to. But we would very much like to say thank you for your time. We appreciate, again, you joining us, and we appreciate your flexibility. Apologies for the slightly later start. As a follow-up to this webinar, you will receive an email. It will have a link in it, and we would really appreciate your feedback. It's the way that we can take your experience and ensure that it shapes the way that we deliver webinars or future training. And we just really want to thank you for your time. We greatly appreciate it. Also, in the follow-up email, we will ensure that you receive a copy of the slides, which, as we said, has a number of QR codes and links to various different types of resources. But in saying that, I'd just like to thank you on behalf of the NADA team for joining us, and stay safe and have a great rest of your day. Thank you.